Hello everybody, this is Claus Schmitt from Heidelberg, Germany. I'm a pediatric nephrologist involved in peritoneal dialysis training and research for more than 20 years. And I'm happy to give a talk on optimizing PD in children. Surprisingly, we do not have a moderator today, so I will do the moderation on my own. And let's just, without wasting time, go into the topic. As probably most of you know, unfortunately, peritoneal dialysis does not allow an adequate control of calcium phosphate and PTH in quite a substantial number of our patients. On the upper part of the presentation, you see the calcium phosphate levels above normal in red and the normal values in green. And you can see that especially the adolescent PD patients, they have high phosphate values, and quite a lot of patients have high PTH values according to the International Pediatric Peritoneal Dialysis Registry as presented by Dagmara Bordzig. And you know that the calcium phosphate and PTH substantially contribute to early cardiovascular disease in our patients in pediatric dialysis. How about control of blood pressure, salt and water homeostasis in pediatric PD patients? In this patient population, you would expect a normal cardiac finding, but unfortunately, and again, this is data from the IPPN, you can see that about 50% of the boys and girls on peritoneal dialysis already have an increased left ventricular mass index, indicating that we unfortunately do not adequately control blood pressure, salt and water. But if you go to real-life data, this is data from adult PD patients compared to hemodialysis patients from the ERA-EDTA registry. It doesn't look that bad for peritoneal dialysis. There are three 5-year periods compared 1993, 1997, 1998, 2002, and 2003 to 2007. You can see that the relative number of PD patients and the absolute number declined in these 5-year periods, but the survival improved, and at least in this period is similar in PD patients to hemodialysis patients. And of course, these data has been corrected for important factors like age, sex, primary renal disease, and countries. So in real life, PD does not do that bad, and so it's not surprising and good to see that the incidence and prevalence of PD patients here shown in the US tends to increase again within the last few years. This has been published in 2016. You can see the absolute and relative number of PD patients as compared to hemodialysis patients increases again. And this is for good reasons, because we have had some important advances in peritoneal dialysis. We have standards on handling of infection, of hospitalizations. We have new cycles with new semi-automated connection devices. And we have new PD fluids with low glucose degradation content, icodextrin and bicarbonate buffer. I just heard that we have a problem with transferring the slides, so we will check the technical part again. So hopefully you can see them now. So I just talked about the 3 upper points, and now other things I will now talk on during this next 25 minutes is on adapted P, also remote patient monitoring, and very little bit on current research activities. First of all, what is PD adequacy? How should we target peritoneal dialysis in children? It has been suggested to take as well as establishing adults also for children. That means for children on automated PD, a total that means dialytic and renal creatinine clearance of more than 63 liters per square meter, 1.73 square meter body surface area in V, and KT over V above 2.1. But there's no specific pediatric reference values, and these adult targets just consider the lower limit of adequacy and cannot be considered as an optimal dialysis. What are the other parameters we should look for? It's optimal growth and weight gain. And we should, of course, minimize the cardiovascular risk, that is a normal blood pressure, hydration status, sodium status, a normal calcium phosphate and PTH in the target range. And of course, we would like to see our patients with a normal psychomotor development and normal schooling. How can we optimize peritoneal dialysis? First of all, we should define the dwell volume for each patient individually. Likewise, we should define the dwell time. I will talk a bit about adaptive PD, how we may modify in certain conditions the regimen. I will talk about remote patient monitoring and how we could prevent peritoneal membrane transformation, that means a loss of peritoneal membrane function. I will not talk a lot about prevention of PD-related infections, since we have the ISPD recommendations, which are very good, and for the sake of time, I will only shortly comment on that. How can we define the dwell volume? One suggestion, one concept is that we measure the intraperitoneal pressure. And the reason is that we know that with an increased intraperitoneal pressure, we expect ultrafiltration loss and toxin reabsorption via the small peritoneal pores in the peritoneum and via the lymphatics, reducing efficacy of peritoneal dialysis. Second, and that's a very important clinical problem, it has been studied in blinded fashion, the patient's perception of the intraperitoneal pressure is mostly incorrect, so there's not a good feeling of the patient on how full the abdominal cavity actually is. You can find a description of the intraperitoneal pressure measurement as suggested by Michel Fischbach in a paper from 2003 in Pediatric Nephrology, giving more details on the procedure. One reason to look for the intraperitoneal pressure is that we have quite a high number of children who develop hernia or leakage until transplantation. It's about 7%. Other studies suggest even higher rates. Potential risk factors are organomegaly, adhesions, constipation, malnutrition, which may lead to a low fill volume and again a vicious circle with malnutrition, abdominal surgery, and of course pain increases the abdominal pressure significantly. And the incidence may even be higher, and here on the right side I show you an example of an infant that developed peritoneal pericardial fistula, which was actually life-threatening. Fortunately, we could transplant the patient when this complication occurred. This is some data from a randomized prospective trial where we repeatedly measured the IPPM with a normal fill volume of 1,000 milliliter per square meter and a small fill volume, followed by a high fill volume of 1,400 milliliter per square meter. And what did we learn? First of all, the IPP was relatively high, slightly higher again when we did the standard 12 filling after 75 minutes again, but the ultrafiltration is also included. It's relatively higher if you calculate it to 100 milliliter fill volume when you have the small dwell of 600 milliliter. So if you fill in only 600 milliliter per square meter, the IPP per 100 milliliter PD fluid is relatively higher as compared to a standard dwell. And if you fill in a very high fill volume of 1,400 milliliter, it's relatively lower. What else did we learn from this study? There are several outliers, so it's not a single value you can rely on. Maybe you have to repeat the measurement and you have to look for the follow-up of the measurements. And there's some intra-individual variation, but it's not that high, 0.3 centimeter per 100 milliliter of fill volume. So what does it mean for clinical routine? If you, for example, have a patient with a dwell volume of 800 milliliters per square meter, and he has only an IPP of 4 centimeter, and this is the mean and SD values which we have derived from several publications. You should be able, you should be able to increase the dwell volume until 10 centimeter water and increase thereby the fill volume from 800 to 1,400 milliliter per square meter. So you can optimize the fill volume by this. And if you look at this graph here with an IPP of 14 centimeter, about 50% of the patients should have a fill volume of 1,400 milliliter. But and honestly, we don't succeed in our patients to have them at that high, but at least we should try to increase it as much as possible. There's a recommendation to keep the IPP in children below 2 years age below 8 centimeters water. This is done just based on eminence evidence, just people with a long experience with IPP management suggest these values. And above 2 years, not more than 14 centimeters water, because there's one publication in the NPT from 2007 suggesting that with a higher IPP above 14 centimeters, you have an increased risk of enteric peritonitis in adult PD patients. There's one other study suggesting that in the patient outcome is birth with high IPP, with IPP above 13 centimeters, the risk of dying or switching to hemodialysis in these 45 patients on automated PD was increased. But of course, this is only observational data, so we have to summarize. This is a convincing concept, but it's only observational evidence up to now, not a single randomized controlled trial looking at clinically relevant outcome parameter. This is an example of what we just recently did. This is a newborn with massive enlarged kidneys bilaterally with autosomal recessive polycystic kidney disease. We had to start with peritoneal dialysis immediately, and to get an estimate of what's going on in the peritoneum, we put in a pressure device, and we were able to monitor the intra-abdominal pressure and to slightly and steadily increase the dwell volume. So this is, of course, not an officially licensed procedure, but in such a difficult situation with our ARPKD in a newborn and dialysis from the very first days, this might help a little bit to get an estimate of how much dialysis fluid you can give the patient. Let's talk about defining the dwell time. You all know the peritoneal equilibration test. We have the high transporter, the high average transporter, in yellow the low average and the low transporter, as established by Brad Varady and published 22 years ago. What does it mean? If I have a low transporter status, I have slow solute transport, clearance targets are actually difficult to achieve, creatinine clearance and KT/V, but glucose is not absorbed, you have a very good ultrafiltration. This changes with a low average, high average, and end up with a high transporter with rapid solute transport, but rapid absorption of glucose, resulting in reduced ultrafiltration, and in some patients with loss of proteins and a reduced serum albumin concentration. But what does it mean in practical terms? If you are a low transporter, you don't need to have frequent cycles. A longer dwell time is justified with less cycles per day. This results in less glucose exposure, and I will tell you later that glucose is really one of the major factors destroying our peritoneum. But since you're a low transporter, you need a long daily dialysis duration and probably a daytime dwell to get sufficient toxin and solute removal. The other side, the high transporter, you need a short dwell time, frequent cycles to get sufficient ultrafiltration, especially in a uric patient, and icodextrin. Especially in this high transporter, you probably give high amounts of glucose, intraperitoneal glucose, and what you can observe then is sodium seeding. That means during the early phase of the dwell, selective water transport across aquaporin 1. That means that you remove water from the patient, but not sufficiently the sodium, which means the patient is probably at his dry weight, but has high sodium concentrations in the body, and you increase thirst, and so you run into a vicious circle with the patient getting more thirsty, drinking more, needing more ultrafiltration. In these children, you should increase dwell time and total dialysis time and consider icodextrin. How often should we do PET? It gives an estimate on membrane transformation over time. Many of the patients go from a low to a high transporter status over time on peritoneal dialysis. And if you have a very high transporter and if you get inflammation in the peritoneum, you may even run into the risk of encapsulated peritoneal sclerosis in long-term PD. So we suggest to perform the PET initially and yearly or in case of clinical problems with peritoneal dialysis. But it's also very important to monitor residual renal function, for example, every 6 months, because this has been shown to be very important regarding patient outcome in the long term. If you lose residual renal function, you have to increase your PD dose. And actually, there is data in adults, but also in children, showing that your transporter status predicts outcome. The likelihood to die or to be transferred to hemodialysis is significantly higher in patients who have a high peritoneal transporter status. And in children, the children on PD with a high transporter status grow worse than those who have a low transporter status. Maybe it's due to inadequate toxin removal and losses of protein into the dialysate. Now let me talk shortly about the concept of adapted automated PD. That's a very intriguing concept, and the idea is that you have short cycles, small fill volume initially, followed by long and large cycles with a dwell volume of about 1,400 milliliters. The idea is that here with the short cycles, you have a low IPP, you have a high glucose concentration, rapid ultrafiltration, free water transport, which means that you get hemoconcentration and dilution of the residual dialysate. While with these long, large dwells, you recruit peritoneal area, small pores, which remove the toxin and the sodium, and these preconditions the following cycles. And actually, there's one study in adults that has shown in 20 patients that in fact with this concept, 3 short cycles followed by 3 long cycles, you can increase the KT/OV with the same dialysis time and the same amount of PD fluid. You increase the creatinine removal, the phosphate removal, the sodium removal, and the ultrafiltration. And the patients on this adapted PD were better regarding blood pressure. So in the long term, you should be able to save glucose exposure to the patients. However, this concept leaves us with a lot of open issues. First of all, the mathematical modeling. The 3-pore model suggests that only 10 to a maximum of 50% higher sodium removal, which is not bad, but the suggested removal by the clinical trial is hard to believe, hard to follow according to mathematical analysis. The findings are not explained by the 3-pore model, which is not that of a problem because the 3-pore model is simply a model, but we lack experimental data on that. The concept of hemoconcentration and dilution of residual dialysate with the short cycles should suggest that we rather have a short cycle followed by a long cycle with a high volume, iterating process like this. We don't have any answer to this. And up to now, we don't really know how we should define the individual regimen without causing an increased risk of hernia leakage with the high fill volume. What we did is a proof of concept study, and I won't go into detail. We just have in a randomized fashion 2 regular normal cycles followed by a small short one, a large long one, and vice versa. I don't go into detail, but unfortunately up to now we were not able to show any significant differences just combining these 2 double mini PET tests. So the concept leaves us with a lot of questions, but you could try in patients where you don't have sufficient dialysis efficacy adapted PD. There are a few registry rounds. Unfortunately, it's a very heterogeneous approach in these patients, but quite a few observational data suggest that indeed it functions. My next topic is remote patient monitoring. What is the model? In the middle, you have the patient, and you monitor the patient. You monitor the fluid type, cycles, dwell time, dwell volume, ultrafiltration alarms, blood pressure, body weight. You can monitor the ECG in an adult patient with heart failure, blood glucose, and diabetes patient. You can allow the patient to give comments. You can have images, video, and Skype transmission of clinical conditions. You can insert an analytical algorithm with red flag system, center-specific data monitor, online automated material ordering, patient feedback system, longitudinal data analysis of an individual patient. You can check the data integrity. You can do video conferencing. And at the end, the aim is to improve patient outcome, do cost analysis, cost reduction, patient flow control, and so on. So it's a very promising concept. And where are we now in PD? There's one dialysis machine supplier who actually offers this since a few years now, or several months in a few countries, where you have the patient at home and the data is transmitted to a platform, a cloud-based platform, and then transferred to the clinician who can answer to the patient and modify his PD regimen. And you have the company which influences the program and can give technical support and optimize the support. What is monitored? You can get an overview on all your patients on remote PD monitoring, remote patient monitoring. There's a red flag system in patients who have some problems. You can individualize these flag system by defining initial failure variance, strain and time, lost treatment time, and so on. So you can customize the system to an individual patient, and you can get an overview on each dialysis session, monitoring the dwell time, the ultrafiltration, any clinical problems. So this appears very promising. In other diseases, which are also prevalent in patients with chronic kidney failure and dialysis patients, for example, heart failure, the evidence that remote patient monitoring is actually working well is there in patients with heart failure. And this is an overview on systematic reviews. So these are all systematic reviews, and this is an overview on these systematic reviews on a number of outcome parameters: clinical outcome, mortality, heart failure, mortality, hospitalization, and so on. And all answered yes. So in patients with heart failure, remote patient monitoring is very efficient, and very high evidence that actually it helps the patient. Only mobile phone-based monitoring, video conference, the impact was unclear. How about dialysis patients? There's one randomized controlled trial in 19 remote monitored patients and 25 on standard care. These were patients with a high risk of problems, adult patients treated in satellite centers. Nurses were taking care of them, the doctors were doing remote patient monitoring. And in fact, it could be shown that the hospitalization days, the number of hospitalizations, and the emergency room visits were reduced, as were the emergency room related costs by remote patient monitoring. So one trial suggesting that at least in hemodialysis patients it is working. And one trial in PD patients, 25 patients were included. Unfortunately, those 25 patients, out of these 25 patients, some refused participation, were taken into the control group, though this is not a really randomized prospective trial anymore. But still, this trial in PD patients was able to show that the number of hospitalizations could be reduced in the group of patients who were remote monitored. And the author stated that it was very helpful to have a video conferencing system with the patient to talk about the problem, to see exit sites, and to see the back and problems with the back, and that you can immediately react based on this video conference. Some 15 years ago, we just monitored in our patient's body weight online and blood pressure online by a digital balance and also oscillometric devices, transferring again the data to our center via standardized system, IBM system. And we also had a very positive experience. In these patients, we were able to see increased blood pressure and to react by reducing the body weight in these patients, to reducing the blood pressure without follow-up in the clinic. And likewise, the opposite, a PD patient, 11 years at home, he suddenly had a lower blood pressure. We increased the body weight and we were able to normalize blood pressure without follow-up. So this is very promising, but of course we need more data to have a clearer idea on it, and that's why we have introduced the remote patient monitor function in IPDN, and we will get a lot of information on the initial remote patient questionnaire, 6-month update, annual remote questionnaires, and the reason for discontinuation. And hopefully in a few years, we can give you more precise data on how good remote patient monitors in children on dialysis actually is. So the last but very important topic is how can we preserve peritoneal membrane function? As you all know, with time on PD, the peritoneal membrane function deteriorates. We get less purification, less ultrafiltration, and in some patients, considerable problems requiring timely transplantation or switch to hemodialysis. One potential means could be that you add ACE inhibitors or ARBs in your patients. We know that these medications preserve residual renal function. Unfortunately, there's only one observational study published in 2009, and this study indeed suggests that you can preserve in patients with ACE inhibition or ARBs the increase in the transporter status as compared to those patients who are not on this medication. How about the low GDP fluids? We were all very enthusiastic about these PD fluids. Unfortunately, we had to realize with the international biopsy study that we have major changes with these PD fluids within less than 6 months of PD. That's a median of 4 months. Microvessel density increased, fibrosis increases, and if you look at the blood vessel density, within 4 months already we see a doubling in the blood vessel density. And this relates to function. The higher the microvessel density, the higher the transporter status. So, and this holds true in multivariate analysis. So, unfortunately, with the low GDP fluids, we still see major changes and early changes in peritoneal membrane function. And this translates in problems with peritoneal membrane transport. The reason is inflammatory cell infiltration. But still, if you compare to the high GDP fluids, we see some significant advantages, and this is a highly matched comparison, low versus high GDP patients. There's a more rapid increase in the submetaphyseal fibrosis and more vasculopathy. And if you look cross-sectional, you can see lower lumen vessel ratios. Okay, fortunately, we are here back again. Sorry for this. So I came to the end of my talk. How can we optimize PD? I hope I could convince you that one means to adapt the dwell volume to an individual patient is to measure intraperitoneal pressure, but keep in mind that it's just eminence-based and not evidence-based. There are not any outcome parameters studied with this measurement, but in clinical routine, the centers who use it feel that this is quite helpful. In contrast, the PET data gives you important and clinically significant information on how you should define the dwell time. Adaptive PD is an intriguing concept and seems to work in quite a few of the patients, also in children, but the overall benefits and risk are still uncertain, and we have to answer quite a few questions. Remote patient monitoring is very promising. Of course, you have to define who should be monitored, how and when. You should talk with your patient about privacy issues. You should consider how you do your surveillance in your center. You get a whole lot of data and the responsibility who looks at the data. And of course, at the end, we have to get a cost-utility ratio for that too. At the end, this should be comprehensive, get a lot of data, but still easy to use. ACE inhibitors and ARB, in addition to preserving residual renal function, may potentially preserve peritoneal membrane status, but this needs to be proven. I've shown you that bacterial peritonitis episodes seem to have only a small long-term impact on peritoneal morphology, provided that these episodes are treated adequately. Overall, low GDP fluids are now recommended in children whenever possible because they preserve the residual function. They mitigate peritoneal vasculopathy, but unfortunately they don't seem to have any short-term membrane protective effects, but probably long-term beneficial effects. So the research should drive for alternative osmotic agents, and another approach is to have locally and systemically active additives such as alanine glutamine, which has been in a phase 2 clinical trial and has been shown to be preserving from inflammation and even improving to some extent the peritoneal transport. And there will be new research consortium. One is called Improve PD, where the risk factors will be defined, animal models to understand local modification, systemic disease, and finally to develop new PD fluids. I thank you for your attention and would like to announce the next ERKNet webinar on September 4 by Max Liebau from Cologne, and he will be talking about primary cystic kidney diseases and ciliopathies. I thank you for your attention, and I'm looking forward to your questions.
Okay, thank you very much, Klaus, for this excellent talk. And I have one question. Since you did not talk about PD-associated infections, could you shortly comment on this topic?
Okay, this is a long topic, so I can just give you a few words on it, but of course, infections are still the first cause for hospitalizations in peritoneal dialysis patients. So what do you need to do? When they go on dialysis, you should train them. You should do retraining in cases of problems. You should assess the exercise score at least twice weekly, have used the standardized score. You should use antibiotic prophylaxis in case of surgery, abdominal surgery, antifungal prophylaxis when the patient needs antibiotics. And of course, you should monitor the infections in your center. You should look for the resistance patterns in your center. When you're a member of the IPDN, you can also do a benchmarking on your center-specific infection rates and complications rate. And one thing which is also proven to be effective is the screening for Staph aureus carriage in the caregivers and the patient to prevent these bacterial infections by application of topical antibiotic. So I'm not sure whether there are more questions. Right now, I don't see any question.
You can use your control panel to ask questions. Please feel free.
I hope the transmission is still working.
I think it's working. Yes. Okay, but we have no questions so far.
So we wait a bit, but if there are quite a few participants still in, so only a few have left so far. So please feel free to ask any questions. We are waiting for questions. So So, but if there are no questions, if everything is clear to everybody, I suggest to.
Yes. So for those who want to see the webinar again, it was recorded and it will be published on the ERKNet website. And thank you for attending the ERKNet webinar. And I think we will close the session now. Bye-bye.